Appreciate it. Thank you very much. Just a little bit about what Monmouth Ocean Hospital Service Corporation is. It's actually a hospital service corporation. We are a nonprofit hospital service corporation made up by 15 acute care hospitals in New Jersey. And our main specialty, the services that we provide to those hospitals, are mainly that of emergency medical services and ambulance services. And to give you an idea of the size or the breadth of the company, we service about 2.8 million people out of the 8.5 million in New Jersey, and that swells to about 4 million in the summer since we have the coastal areas, in about 1,800 square miles of the state. So I'm going to talk to you a little bit, given only 10 to 15 minutes to talk. I'm going to really focus more on the lessons learned from Hurricane Sandy recovery versus emergency management, preparedness, and planning. I think that while it's different, a little different everywhere, the main things exist throughout most of the nation. And I'm going to talk a little bit about what we've learned from Hurricane Sandy and some of the suggestions that came out of that. So first slide, please. Just to talk a little bit about the short-term phase. And again, I was asked to kind of keep it to 2 or 3 bullets for each short-term phase. And if you know me, you know I kind of take these requests seriously, so you'll see it there. Establishment of adequate shelters for people with special needs. Obviously, there was a number of shelters set up throughout any of the coastal regions affected by the hurricane. And while we do have 3 designated medical special needs shelters in the state, they're well known by those that are absolutely positively in need. But those people that kind of are a cross between somebody that might fit that quote-unquote special needs population, those that don't, are always the ones that kind of fall into the regular shelters. And some of the things that we found were issues including, just the need for, specialty providers, mental health providers, security folks, medical personnel. I mean, every shelter ultimately has some medical personnel and some security, but typically where you start is really where you start, and it's not really enough to be adequate for the needs of each shelter. Some of the little things that may not have necessarily put somebody into a category of the special needs shelter, and thus the movement of them to that other shelter that's usually a distance away, is need for, say, additional space or electricity. A lot of New Jersey has a huge senior population, and while there's not a lot of people that are on ventilators that may be in a regular shelter, there are tons of seniors that are dependent on oxygen generators. So while it doesn't seem like a big deal, one thing they need is they need electricity, and they need to be near some electrical outlet in order to have that oxygen. Now, will all of them suffer as a result of temporary loss of that? Not necessarily, but it will certainly be exacerbated given time. So another area was the separate area for people with mental health issues. Again, same kind of concept. Those with extreme cases that are diagnosed and that are in certain facilities that need to be evacuated, they typically get to the right place. However, those folks that are usually independent or semi-independent will come to a regular shelter. And unfortunately, they do not have the resources, at least early on, that these folks need. And they're typically placed within everybody else. And in some cases, while they may be dependent, they aren't necessarily able to deal well with the stresses of the evacuation, et cetera, causing a number of different problems. Also, just want to throw one in there that we saw a lot of was the fact that those folks with pets coming to shelters. Now, certain shelters are, without a doubt, designated for pets, but it wasn't really that well known. And what would happen is people would come to shelters with their pet. Sometimes they'll have their crates, sometimes they won't. Some places will take them, even though they're not supposed to. Some won't. It really wasn't very consistent. And then you just had a number of different situations where people will not stay where they should, even because of the fact that they wouldn't take in their pets. Another area in the short-term phase that we saw was issues with prescriptions and medications for people that evacuated without theirs. A lot of these folks that did have a lot of time ahead of them to evacuate, but given it's kind of like planning for a vacation. You plan for a vacation, you have lots of time, but you always forget something. And a lot of times it's these medications. And again, given a large senior population, and those that with multiple medical issues, the fact that they leave their medications or some of their medications behind is a big problem. And for those areas for those folks that were on barrier islands, there was no going back, no matter what. And so they were without it. And a lot of these folks with multiple medical conditions, they would get given a day or two without their medications, they're going to be in trouble. And we found a lot of those folks that didn't even know what they were taking. They just kind of, like somebody else said earlier, they knew it was a white, round little pill. They don't know the dosing of it. They don't know specifically what it's for, et cetera. And that became an issue. While we do have resources that would fill prescriptions and things like that, it was a major issue where we tried to actually identify it. And given the weeks of lack of electricity and communications, trying to get to their private physicians to get the records or the hospitals, et cetera, were very difficult. Emergency medical services supply chain, also in the short-term phase. When I say supply chain, I talk about personnel and resources. And, when people need help, they call 911. And one thing that we don't really think too much about is these long, drawn-out disasters. And when the emergency personnel need help, who do they call? Typically, there's lots of mutual aid available, but when something is so widespread as Hurricane Sandy, there were some issues to take into consideration. So we wanted to talk about things like personnel. People would typically work while there's always, given guidelines to say, don't work past X amount of hours, or don't fight a fire time X amount of minutes. These kind of things typically go out the window when it's a disaster, and people will work as long as they possibly can, physically and mentally can. So thinking about moving folks, we did have a lot of resources come from out of state, but again, that kind of came after the fact. Resources such as equipment and supplies, we do have stockpiles and we do have mutual aid, but again, depending on what the actual need is at the moment, we found ourselves running short on certain things. Moving to the next intermediate phase, next slide please. Transportation to scheduled doctor's appointments and special procedures. So given that, weeks to several weeks to even a month after the disaster, we found there being issues of transportation. Now, while there's plenty of transportation from a county and a local level, the problem that we had was certain patients that just didn't have the ability to get into a typical van or a typical vehicle to go to dialysis or to go to some sort of special procedure. Now, yes, there were ambulance services available, but getting them from the shelters to their appointments at different places was logistically difficult. Whereas normally, if you're calling from home or you're calling from a nursing home or what have you, extended care facility, it's so much easier. But now there were some issues with difficulty with logistics, and that was something that really needs to be addressed. Now, while you're not going to get people that are getting elective surgery done coming out of a shelter, typically, you are going to get those people that do need to have certain procedures that have been pre-scheduled or those that are absolutely necessary that are regular procedures such as dialysis. Another issue with the immediate phase that needs to really be looked at in the future is the transportation, the appropriate transportation again from those local shelters to the appropriate long-term shelters. Some of the big shelters that we had that worked great were in schools. Now, when schools needed to obviously start up again and finally received their power and everything back, and we're talking a week to 2 weeks after the storm. So a lot of these kids were out a long time. And the good news about that, it was a great shelter and it was working fine. But when they got back into school, there were some areas in some schools that just could not handle the shelter and the school at the same time, and these people needed to move. And the typical folks that are ambulatory, that's not a really big deal. They can just get on the bus or a van and they can be moved. But a lot of those other people that have special needs, again, logistically it was difficult. Oddly enough, we had so many ambulances and resources available, but there was a lack in communication between people setting those up and the actual folks that are actually going to do the transportation. Next slide, please. In the long-term phase, certainly rebuilding of damaged or destroyed healthcare and emergency service facilities is paramount. Certainly, you got to consider a number of things. Is there a need for permanent relocation? A lot of the emergency services that were located on the barrier islands were decimated and were gone. Not even decimated, but gone. And the thought was, are we going to rebuild there at all, or are we going to move somewhere else? And if you're on a barrier island, you know that there's really not too many options. So what are we going to do? Are we going to have upgrades such as elevation? Are we going to fortify it for hurricane status, which may not have been done because these have been around for decades? These all have to be considered. And one of the problems we found out from a rebuilding standpoint is for those that needed to be rebuilt, because they were either municipal or county government or what have you, in that rebuilding process wasn't, like a private, where you could basically just say, okay, I'm going to build, I got the money, I'm going to go ahead and do it, I'm going to go ahead and get the plans, and I'm going to start building. But a lot of these had to be done through RFPs, and a lot of them have emergency spending limits that weren't adequate. What would happen is these agencies would be so delayed in rebuilding that all the local builders that would otherwise do this are now taken up by the privates. And so that was a problem housing a lot of these emergency services that lost their facilities. Immediate upgrading of both public and private emergency management management and business continuity plans through lessons learned. I mean, I can't say this enough that while after-action reports are complicated sometimes and take a long time to put together adequately, the way I look at it is if you have a hurricane, you could have a disaster today, you can have another one tomorrow. And while it's unlikely that, everybody used to say it's unlikely that you're going to have a lot of hurricanes hit New Jersey, well, think about Irene the year before. While it certainly wasn't as bad as Sandy, it was back-to-back years, and nobody statistically would have planned for that. So I really say that while you have hot washes and you have some after-action debriefs, it doesn't usually get to the right people. So things like that, of these that I've discussed so far, these are things that need to be brought to immediate attention so that if you have a hurricane 2 weeks later, a month later, at least some of these things can be addressed versus waiting for the official after-action report that may come months or a year later. Evacuating of hospitals and extended care facilities was a major issue. While certainly it's a tough decision to say, I got to pull the plug on the hospital and immediately evacuate everybody in the entire hospital, hundreds of people. Waiting to the last minute is not an option. And we found that out a lot throughout the coast, north and south New Jersey, is that people were waiting. It was getting worse, and worse. And by the time a couple of the hospitals said we need to evacuate, it was too late. We physically didn't have access from an ambulance standpoint to get to the hospital at a certain point and actually move these people out, and that's a major problem. A lot of the hospitals actually had, feet of water on the first floor, and some were able to still have electricity, and their generators were elevated, and others were not, and it knocked out the entire facility. So that really has to be done. That hard decision really has to be made earlier, and sometimes you make it. It's like closing school for your kids. They look at it, and they say, we're going to close school, and then nothing happens. And sometimes that happens, and sometimes it happens the same with something major like the evacuation of a hospital. The last thing on long-term that I would suggest that we experienced was taking a really good look at critical incident stress management for emergency responders. There definitely was mental health folks around that in immediate need. They were there to address any issues, but there really wasn't anything formal as far as critical incident stress management for emergency responders in an official capacity, and that's something that really needs to be looked at from a stress point of view and a PTSD outlook. Just to talk very briefly about funding. From pre-hospital medicine standpoint, when you look at pre-disaster, pre-hospital services are dependent on really the type of service or commitment. What I mean by that is private versus government, contracted services versus mutual aid, and volunteers versus paid. New Jersey is made up of all those things. So what I mean by that is, there's really, if you're a contracted agency for a particular town or a particular area, you're going to have more need for funding to have disaster preparedness equipment and resources available than if you are a mutual aid from, say, western New Jersey that don't typically see these kind of things. Versus also private versus government. Government certainly has the access to a lot more funding. Nobody ever gets what they really want, but compared to a private, it's a tremendous amount. Some grants, but really dependent on the service model. For instance, Monmouth, we are a private nonprofit, and we really don't fit into the category of a lot of other emergency medical services providers when it comes to grants. So we are independent, and self-sufficient. When it comes to resources, in general, I would probably say that it's probably the same throughout the country, and that is, you really got to look for the biggest bang for your buck. You have X amount of dollars to spend. What is the likelihood of using something? It's nice to have it if you have the big one, but how often are you going to have that big one? So would you rather spend money, maybe not so much EMS, but would you rather spend money on sandbags, which can make a tremendous difference for the community, or would it be a communications vehicle that may not be used but a couple times a year? During the disaster, all available resources are typically used. Reimbursement is worked out later. I think that's pretty much a given. Resources, whether it be paid services or volunteer services, people are going to work, and nothing's really going to be held back. You're going to be servicing the regular community needs as well as the emergency needs. And for the post-disaster, typically the same thing really applies as far as all available resources being used. Typically, when it comes to shelters and medical necessity for those, then it starts maybe getting into a situation where if you're not getting paid for that service, you're going to find somebody that is going to get paid for that or reimbursed for that. But in general, the emergency services community typically aren't ones to say, I'm not getting paid for it, I'm not going to do it for you when there's a need. And typically reimbursement is worked out later via the state or federal means. So that's kind of it in a nutshell. And I'll be happy to address any questions should anybody have any.
Thanks so much, Scott, and we'll get back to you. Just hang on. Betty Pfefferbaum, you are the chair of the Department of Psychiatry, College of Medicine, University of Oklahoma Health Sciences Center. And Betty, your slides are up on the screen.